In this condition, the word acute indicates that the injury occurs within hours to days. The respiratory distress here indicates that there will be hypoxemia and respiratory insufficiency. Here it is a syndrome, it's not a disease. Here the causes are many and the pattern always is the same. Respiratory failure occurring within 1 week of non-clinical insult, and the insult here should not be atelectasis and fluid overload, heart failure, and we have pleural effusion. These actually they doesn't lead to the ARDS, because in case of acute respiratory distress syndrome, 2 points are very important. One is the alveolar membrane dysfunction. So there will be some damage to the alveolar membrane in case of acute respiratory distress syndrome, and inflammation is always present. Now let's see these conditions, why they doesn't lead to ARDS. Number one is we have atelectasis. In case of atelectasis, there is collapse of alveoli, but there is not any damage to the alveolar membrane and there is no inflammation. That's why atelectasis doesn't lead to ARDS. Second is oral pleural effusion. In case of the pleural effusion, there is fluid in the pleural cavity, but there is no fluid in the alveoli, and the fluid that is present in the pleural cavity is not because of damage to the alveolar membrane. Next we have heart failure, and because it is because of the left-sided heart failure, because we know that right-sided heart failure there is increased fluid load in the periphery, not in the lungs. But in case of the left heart failure, you can see my video, the link of that video is in the description. But till now, believe me that there will be increase in the pressure in the left atrium, and that leads to increase in the heart-sided pressure in the venous system, and as a result there is fluid that moves outside, but that is not because of alveolar membrane damage. And the fluid that is present there is not rich in proteins, but the fluid in case of ARDS, the exudate, is rich in proteins. Okay, so that's why those conditions they are not included in the as clinical insults that leads to ARDS. But now what are those conditions that leads to ARDS? So number one cause is pneumonia. Okay. Second one, we have sepsis. Then we have pancreatitis, transfusion reactions, and many more. So now let's move towards the pathogenesis of this condition. As I have discussed earlier, that there will be endothelial epithelial lining injury, that is known as capillary alveolar membrane. Is that there will be inflammatory reaction. Suppose the insult is anyone, and as a result of that insult, there will be injury. Okay. Within 30 minutes of this injury, the pulmonary macrophages they become activated. They are the first one to become activated because they are resident there and they are present at the lining of the alveolar and capillary. They are present here. So that's why they are the first one to become activated, and when they become activated, they are going to release interleukin 8, interleukin 1, and tumor necrosis factor. These ones they are going to cause the endothelial activation. Okay, they are going to cause the sequestration of the neutrophils from here and many more. But this interleukin 8 is going to act as a chemoattractant for neutrophils. So the neutrophils they are going to rush towards the alveoli. So they will be present in the vascular spaces, they will be present within the alveoli and in the interstitium as well. So when there is increase in the number of neutrophils, there will be release of proteases, reactive oxygen species, and cytokines from these as well when they are performing their phagocytic functions. And these proteases and these reactive oxygen species, they are going to cause damage to this lining. And when these are going to cause the damage to this barrier, there will be fluid exudation. Okay, and this fluid that is going to come here will be richer in proteins, and as a result there will be hyaline membrane formation here. And what is hyaline membrane? So hyaline membrane is actually we have necrotic cells, these pulmonary epithelial cells, plus fibrin rich exudate. There will be type 2 pneumocytes dysfunction. There will be damage to type 1 pneumocytes and their necrosis can occur. That's why hyaline membrane that forms here. So in case of morphology, we have three stages. The first one is acute, second is organizing stage, and it is not the recovery stage. Here hypoxemia is present, the lungs are still stiff, and then we have the recovery stage that may or may not be present. Okay, so now let's start the acute stage. As I have told earlier that there will be disruption in this lining, the endothelial epithelial lining. So when there is disruption here, there will be increase in permeability. As a result of increase in the permeability, we have already discussed that there will be increase in exudate here. There will be protein rich exudate that is present here, and there will be hyaline membrane formation, and the collapse of this alveoli can occur. In case of the pathogenesis, we have discussed that there will be increase in the number of neutrophils in the interstitium, in the alveolar space as well, and there will be damage to the type 2 pneumocytes, and we know that their function is surfactant production. So if these are damaged, then the surfactant production will be decreased and the lung compliance will also decrease. There will be some vascular changes as well that includes microthrombi formation. So we have interstitial edema as well that occurs here. So next we have our organizing stage, and this is a little bit interesting. Here we have our alveoli. So I have told earlier that there is exudate that is present here. So in case of organizing stage, suppose this is the exudate, then this exudate is going to decrease. And there is hyaline membrane formation here, and it is also decreasing, it is reabsorbing. And the fibroblasts, they are going to move inside. And when they are moving inside, then at the end, we are able to see granulation tissue here. So these are the changes that are occurring in the alveolar space. Next, we have the septa here. So within the septa, the fibroblasts, they multiply. And when they multiply and they release collagen, then this collagen will lead to thickening of the alveolar septa. Third is the cells that are present here. And if this is type 2 pneumocytes, then there will be hyperplasia of these type 2 pneumocytes, and surfactant is going to increase in. So this is the picture of the organizing stage, and as I told that the septa, they are thickened and the surfactant production has not reached that level, and there is still some exudate that is present here. So here the lungs are still stiff and it is not recovering stage, and here this is the picture of the organizing stage. And next we have the recovery phase, and there may be complete recovery or there may be incomplete recovery, and there can be chronic disease, like we have restrictive lung diseases that can occur because the collagen that are formed here is going to increase in number, and that will lead to permanent we have permanent interstitial fibrosis. And here when there is a complete recovery, then this is going to be removed from here, and we have the lining completely repaired. So the clinical picture, the clinical features, the prognosis is mostly poor in those who are in advanced age, and in those whose disease causes multi-organ failure. So if the recovery occurs, then it mostly takes 6 to 12 months, and that's all about acute respiratory distress syndrome. Hope you will like this video. If you like this video, click on the like button and also subscribe to the channel. Thank you so much for watching this video.